Okay, so that's it for all of our announcements. Our speakers today are faculty at the University of Chicago, and they are going to be sharing their expertise. We have Dr. Marshall Chin, Dr. Aniruddha Hazra, Dr. Sonali Paul, and Dr. Charles Rhee. And I'm going to go ahead and stop sharing my screen and throw it to Dr. Rhee, who is going to be speaking.
Perfect.
Okay, great.
Am I on? Hello, everyone. Happy Pride to all of those who celebrate. I thank you all for having us and joining us for this talk to kind of end Pride, the Pride Month. So I'm going to be emceeing this presentation. So a little bit about myself. I'm a palliative care physician in the section of geriatrics and palliative medicine. I also have an interest in LGBTQ medical education and work closely with the medical school on course development in that arena. And so I'm going to be joined by two of my wonderful colleagues, Dr. Sonali Paul in the section of gastroenterology and Dr. Aniruddha Hazra in the section of infectious disease. Just to start things off, we're talking about what we would present during this lecture. It's quite a broad topic, and there's so many directions we could have gone with it. Particularly relevant for this lecture series is the fact that there are so many health disparities within the LGBTQ community, not just in infectious disease, but in cancer as well. There's lots of data indicating the higher incidences of, for instance, gynecological malignancies due to lack of screening in women who have sex with women. And then, of course, within the transgender community, we are only now starting to get quite a lot of data about just the immense toll that kind of the lack of proper medical care is taking on them with the incidences of, or rather the decrease in appropriate cancer screenings and the increases in malignancy. But we thought we wanted to kind of make this a little bit more of a personal talk. So, we decided to go back to basics and kind of deconstruct some of the very basics of LGBTQ health, as well as share our own journeys and stories as both providers as well as sometimes patients in navigating the healthcare system. And with that, I'd like to start with introducing Dr. Sonali Paul, who will start us off with kind of an introduction to LGBTQ health issues. Dr. Paul?
Great, thanks so much, Dr. Rhee. So I will be talking a little bit about LGBTQI plus kind of 101, as there's a lot of terminology that can sometimes be a little confusing and overwhelming. So just one thing that kind of to start us off, so this is a very much a safe space, grounded in respect. So if there are questions, and even if you're not sure of the right terminology, there's someone probably else with the same question. So please feel free. This is the right forum to ask, and it's definitely a safe space. So in terms of LGBTQI, L is for lesbians. That's usually referred to females that are attracted to other females. Gay is kind of an umbrella term, usually referring to males, but some women do identify as gay. I am one of those women that identifies as gay and not as a lesbian. Bisexual is being attracted to both genders, transgender, and then there's queer, which is the kind of an umbrella term, which is very much made to be inclusive. And the history of queer is a little, it's interesting because back a while ago, it used to be actually a derogatory term. And so the communities really kind of reclaimed it. And again, not everyone embraces queer. I know a lot of, especially some of the older LGBT folks aren't as fond of the word queer, but it's certainly something I use to describe my community. And then there's folks that are intersect, and then there's plus, which is just many more identifications that are not exhausted in this list. So there's non-binary and asexual, for example. So the biggest thing is not to assume, because we don't really know who is gay or who identifies in this community. And so there's about 11 million people that identify some form of LGBT in the US, and about 700,000 identify as transgender. But really knowing that this is likely a gross underestimation, because especially in the transgender and intersex population, because this data isn't routinely collected really anywhere. It's certainly not in the census. And just now, electronic medical records are starting to routinely capture the sexual orientation and gender identity data, which is so important. So sex versus gender. So they're two very much different things. So gender is socially constructed. It's our roles, our behaviors, and really defined by our culture. And so it's kind of the cultural expectation. But sex is really a biological attribution of humans and animals. So these are chromosomes and really our gene expression and hormones and anatomy. So really important to know the difference between these two. And then there's gender identity. So gender identity is really how you identify, so how one sees themselves. And there's also gender attribution. So how is your gender perceived by others? So there's also sex assigned at birth, so what the medical community labels you, and then there's gender expression, how you want to express your gender or display your gender. There's gender normative and cisgender, so this is someone's sex assigned at birth that corresponds to their gender identity and expression. And then there's transgender, which is an umbrella term, but also when one's gender identity does not match their assigned birth gender. But it's really important to know that gender identity does not imply any specific sexual orientation. So gender identity can be a female, male, non-binary, a transgender male, so a female who transitions to a male, or a transgender female, so a male who transitions to female. And then sexual orientation is really someone's personal, emotional, and or physical attraction to people of the same gender and or a different gender or both. And so these are the terms that we usually think of when we think of sexual orientation. So lesbian or gay, bisexual, straight, asexual, or again, it's just there's a very heterogeneous group of sexual orientations as well. We often talk about preferred pronouns. And so these are the pronouns that you personally would like to be referred to. And you can see a lot of us have them on our own Zoom identities. So for my pronouns are she, her, and hers. And then there's he, him, and his. And more on the non-binary spectrum, there's they, them, and theirs, which is used as singular. But there's also gender neutral ones, including Z, here, and here's, and Z, zier, and ziers. So again, it's never, I never assume anyone's pronouns. I always ask, especially in a clinic visit, I always ask what people's preferred pronouns are. And these are the most common, and certainly not an exhaustive list. And it's really, I mean, using preferred pronouns, I think, it's above just kind of not wanting to misgender someone. It really kind of shows that you're, thinking about equality in this arena. So this is all important because the LGBTQI+ community, we have a history of discrimination, violence, and oppression. So not only is this found in kind of other facets of our lives in terms of especially youth bullying, housing discrimination, employment discrimination, insurance, retirement benefits, medical insurance, and then really in healthcare, there's really just a knowledge deficit among providers. There's access issues and kind of outright discrimination and homophobia that can happen within the medical system. So I just wanted to take a few minutes and go through some of the kind of historic events that have really shaped the community. So especially how kind of medicine has kind of made, how medicine has kind of tainted this community a little bit in the sense that, so in 1952, homosexuality was actually considered a mental disorder by the DSM. So thankfully it was repealed in 1973, but for 20 some odd years, homosexuals were considered to be mentally ill. In the 1950s, there was a lavender scare. So I don't know how many people know this, but it was a time of kind of McCarthyism, and there was a mandate that any gay or lesbian individual that was working in the government were basically laid off because they thought they were going to be spies and secretive people. So, that there was a massive kind of exodus or firing rather of gay and lesbian people from the government in the 1950s. Just thinking about Illinois, because we're based in Illinois, so homosexuality was actually decriminalized in 1961. So, thinking kind of in history-wise, that's not that far long ago. And then really 1969 was the start of the LGBTQI plus kind of movement with the Stonewall riots. Stonewall is a bar still there in New York City, and that's when police officers would come in and kind of raid these bars and take anyone that was gay to jail. And so this was happening, and then it was the first time that everyone kind of uprised and joined together to protest. So then in 1993, there was Don't Ask, Don't Tell in the government. So you could serve in the government, but you couldn't openly be gay or identify it within the community, which was eventually repealed in 2011. Also in 1996, there was the Defense of Marriage Act, which basically made marriage between a man and a woman only. And this was kind of a federal, on a federal level. 1998, many of you may remember Matthew Shepard was killed, and this was considered a hate crime because Matthew was gay, and really kind of his death was terrible. And I think for a lot of people, like I was growing up in the 90s, and I knew that being gay was probably not something I should be talking about to other people, because this could happen. And then lots of other things did happen, but in 2015, really same-sex marriage actually was legalized, and so we just came up on our 6th anniversary just this past weekend. And I remember that day being kind of the first day that I felt like a part of, I felt like a person and recognized in the government. And then 2016, there was a horrible mass shooting that was considered a hate crime at Pulse in Orlando, Florida, where 49 people died, and all kind of LGBTQ. And, it was just such a terrible, and it was around Pride weekend, it was during Pride Month. And I remember it being just such a horrible kind of event in our community. And then, the last administration, there were many things that happened, just too many to name. There were a lot of threats to our rights, especially to our transgender colleagues and folks and patients. So many things happened, but thankfully, with this new administration, many good things are happening, including, I thought this was really great. So Rachel Levine is actually the Assistant Health Secretary. So she's the first transgender person serving in the government at that level, which is great. So just thinking about discrimination, so there's homophobia, which is the irrational fear, aversion, discomfort, or dislike of LGBTQ people, which can lead to discrimination, violence, and victimization. And then there's heterosexism, which is an ideological belief system that maintains heterosexuality is inherently superior, and any other sexual orientation is considered wrong or less. And then there's heteronormativity, so a phenomenon where heterosexuality is woven into society as expected sexual orientation. And really the heteronormativity is really woven throughout the fabric of medicine, which makes getting healthcare when you identify within this community a little bit more difficult. And then there are social determinants of health. So in 2016, LGBTQI plus was labeled as a health disparity population. And so all those things that we kind of talked about all affect the health of the community. So there's economics, there's the neighborhood and physical environment, education, access to food, community and social context, and again, the healthcare system. So the social determinants that are specific to LGBTQI plus populations, so there's social stigma, there's rejection by family members, abuse and violence, unfair treatment in the legal system on both state and federal level, and this constant need sometimes to hide some or all aspects of one's life. There's actually a lot of lack of health insurance amongst the community, and really a shortage of culturally competent health providers, and that kind of stems from our own overcomings or shortcomings in medicine and kind of the way we train, as Dr. Rhee was mentioning. There's also a lot of intersectionality that does happen. So intersectionality, there's overlapping of social identities and related systems of oppression, domination, and discrimination. So just because someone identifies within the LGBTQI plus community doesn't mean that all of a sudden they're not also, I'm South Asian. So when I was coming out and struggling with that, I had a lot of issues because my South Asian heritage and culture really affected the way I viewed myself and the way my family viewed me. So this is really kind of an important thing to think about when we think about our patients as well. And then there's a phenomenon of minority stress. So this is when folks that experience institutional and interpersonal stigmas because of their race, ethnicity, gender identity, sexual orientation. And it's really associated with negative health outcomes. And so you have kind of general stressors that affect health outcomes. And then there's these external kind of minority stressors of stigma, discrimination, violence, abuse that affects it. And then there's internal, kind of the internalization of negative societal attitudes and rejection. And that also develops and leads to negative health outcomes. And then eventually one hopes that we develop resiliency and that can overcome and help and improve our outcomes. So with that, I'm going to stop sharing my screen and I'll give it back to you, Dr. Rhee.
Wonderful. I don't know, Dr. Chin, did you want to moderate this, or I'm happy to moderate this section? And you're muted, by the way.
Got the mute on. I want you to moderate, Charles, and as my segment, I'll share some of the stories from our patients.
Of course. So this is, a part where we decided, in order to kind of give it a little bit more of a personal touch, we would kind of share some of our own stories navigating, the healthcare system, both, as I said, as provider and sometimes patient. And, to the other members, some of the questions that, to keep in mind as we, share our stories is, thinking about where we've come from, what in 2021 do you feel we have most to celebrate? And in what areas do you think that we should prioritize for more progress? Does anyone want to start? Sonali, you've already alluded to parts of your personal life, so.
Sure, no, I'm happy to. So, I officially, I knew I was gay since I was probably 10 or 11, but didn't officially come out until college, and then really kind of in medical school, basically my first job out of fellowship was the time that I actually interviewed and was openly gay on the interview trail, because I knew I didn't want to be in a place that wasn't going to accept me or my family. I'm married, I have a wife and a 6-year-old son. And I think, I've interfaced with healthcare for I feel like my whole life. And I think it was most alarming about how heteronormative medicine is when we had our son, and I carried him. We used a sperm donor, and he had some issue at birth, which was very not serious, but there was a doctor that came in unattending and basically just demanded to know all these things about the father and just had no internal realization that he was talking about a father that was non-existent, right? And because my son has 2 moms. And I think navigating, it was kind of the first, it was like, he was 2 days old and I was incredibly tired and sleep deprived. So I didn't really have time or energy for, that teachable moment. But I think since then it's been really challenging to have a system where everything is labeled as binary, mother, father. My son had an allergic reaction. We went to the emergency room and the nurse asked us which one was the real mother, which is sadly a comment I get often when he's out with us or in medicine. And every single time there's a form that we have to fill out that says father's name, crossing that out. And if it's electronic, there's no way to cross that out. So I think seeing that has made me even more so, and experiencing that has made me even more so kind of more passionate about this and how we can make healthcare equitable.
Yeah, thanks so much for sharing that, Sonali. I echo a lot of the same sentiments. I think growing up, I never really had a physician that really thought about my sexuality or even really talked about sex at all, which I thought was, a huge missed opportunity in terms of just being able to reach out to adolescents and young adults about sex and other behaviors. I think I never felt the support that I would want from a physician. And I think that's what really attracted me into the field I'm in, to be able to fill that void and provide that for others. I think, when you're able to make a therapeutic connection with someone by providing affirming, compassionate care, and we do that, in several different ways, but for being able to provide affirming care that affirms not only their gender identity, their sexual orientation, but just who they are as a person, that's like, that's monumental. That's so critical in being able to keep people retained in care, make people empowered about taking care of their health. And that's really why a lot of these conversations are so important, to make sure that all of us that are health professionals and provide care are really able to connect with patients and really be able to provide the care that they need and deserve.
Wonderful, thank you, Anu. And then I guess it's my turn. I've been thinking what to think about. One thing with my own journey through life is, I'm a little bit older, but I'm in a very odd cusp. I'm a little bit too old to be a millennial, but at the same time, I'm at the very tail end of, I guess, Gen X. And so growing up during my formative years, which would be like the late 80s, early 90s, it was a difficult time. The only images of gay men at the time, we were in the height of the AIDS epidemic, and that was pretty much all that was seen in the media and in the press. So it was a very difficult time to kind of come to terms with my own sexuality. I was fortunate in that in the mid 90s, after college, which is about when I came out, I was living in the San Francisco Bay Area, which is it was, even back then, it was a very unique bubble of LGBT culture. So I was, while at the same time, I was being bombarded by these kind of, disturbing images in the media and, very negative stereotypes. So, I was also in some ways protected. It wasn't until I kind of left that bubble and came back to Illinois for medical school. And this was in late 2000s. I kind of got a shock to the system where, I'm interacting with people outside of this bubble I've been living in, comfortably for 10 years. And, they had kind of deer in headlights look at any time, sexuality was mentioned within our lectures or, within standardized patients. And, I still think that, we kind of laugh within the healthcare profession, but at the same time, it's one of those kind of bitter, ha 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 laughs. Whenever there was a board exam question, and it was, for our many tests that we have to take as medical doctors, and it was, some 43-year-old male who has sex with men, male who has sex with men. The question was almost inevitably about STDs or HIV. It was that level of stereotyping, which actually still might exist to some degree. But, the fact that it was so pervasive, even within the medical community and the medical training community, kind of led me down my path of being interested in kind of educating the next generation of doctors. So even those who are not familiar with these, with LGBTQ, people, at least have the basic knowledge to communicate and make, their patients feel, not unsafe. And so that's pretty much my career path. And my interest in LGBTQ education.
So thanks so much, Charles and Anu and Sonali, for sharing your personal stories and organizing this panel. So I'm Marshall Chin. I'm a general internist, and I do a lot of health disparities research with a focus on advancing health equity. And one of our projects is called Your Voice, Your Health, where we've interviewed about 200 LGBTQ people of color, basically hearing stories and trying to come up with themes and recommendations to improve healthcare and outcomes for these LGBTQ persons of color, intersectionality issues, as Sonali mentioned. And so in the chat, I put down a link to 5 videos that we did, videos of 5 of the patients. And I just want to share like a snippet of a quote from each of the 5 patients. I won't really comment upon them, but they raised issues that we'll come back to when we engage into a wider panel discussion and question and answers in this overall session. So the first quote is from Vita, who's self-identifies as a Black, trans, non-binary, femme individual. And Vita was talking about how her identity affects her health and then her experience with the healthcare system. Vita says, one of the ways I think being a Black transsexual woman affects my hypertension directly is stress. I hadn't had super high blood pressure until I came out. It's a mental exercise to leave the house now, you know, and to feel confident enough that you would get from point A to point B and back to point A safely. On a racial level, the societal stigma that Black people aren't intelligent, which, like, skip the respectability of simply having a degree, experience teaches you a lot about themselves and the types of things they need. I've noticed a very real sense of entitlement in medical health professionals and mental health professionals around hypertension management, sexually transmitted infection prevention. I'm a doctor. I know more than you. Here's what you're going to do. The second patient or person is Sam, who identifies as an Asian American, Taiwanese American, biracial, queer, pansexual, trans masculine, gender fluid, genderqueer individual. And Sam says that, yeah, I think it's important on multiple levels for my healthcare provider to know about my gender identity and gender expression. What would be more important to me is that they have a context for that, rather than it being on me to disclose that doctors and providers already have an awareness around issues so that they're not already assuming that because my legal sex says this, that means this about me. It would be important for them to understand and get my gender identity and expression as long as they didn't create a box for me in another way. I would want a doctor to understand that there's even a spectrum within or outside of that. Not all trans masculine people are going to identify as traditionally masculine. The third person is Aurora, who's a Mexican American or Latina, identifies as lesbiana or lesbian. And talking about these 2 different cultures, Aurora says that I could never connect with. I think the only thing I had to go to were nightclubs and bars, and the bars that were available were primarily white. So those have been the challenges in the Latino community because of the fact that we are, you know, you're female or male, and you do certain things a certain way as a male or a female. You look a certain way as a male or a female, and I bend all those rules. So fourth is Don, who identifies as a cisgender, pro-feminist, gay, single gender loving man of African descent. And again, with the intersectionality theme, Don says that being African-American has been the predominant identity in my life, not just for me, but in terms of the way people identify me and interact with me. The overwhelming reaction is based on the fact that I am African-American. Race is really a very strong determinant of my interaction in society. I have been aware of mortality and threats to life for a long time. Everything from lynching to neighborhood shootings. There's a constant threat to life and safety for African-American men. You know, we have the least amount of support in going through life situations of all the social aggregates. I have never been in the LGBT community just a gay man. I have always been a Black gay man, and that has determined in most cases how people interact with me. For a very long time, Black people were not particularly welcome on the Strip, on Halsted Street, in the center of the geographic gay community. Then finally, the last quote comes from Rhee, a Latinx trans woman. And this is, she talks about a theme that is related to one of Charles's points. There's so much stigma associated with being trans, especially a trans woman of color. And a lot of times they push that stereotype upon you. And the biggest one, obviously, is HIV in your community as trans identifying people, especially as trans women of color. It's a terrible thing. They think I'm positive, or they're just already assuming I'm HIV as a trans woman, or that we're completely infected with every sexually transmitted infection available. They put the gloves on right away, a walking STD. They don't think we see that, we do. It's a big reason why a lot of distrust in the medical field is insulting. And just to remind you, I put in the chat the link to the complete videos of the 5 persons. So we're now going to go to a segment, the last half hour of the session. We're going to do a panel discussion and question and answers. And I'm going to start off with just 3 foundational questions to ask to Sonali, Anu, and Charles just to get things started. Then we'll open it up to all you all for question and answers, which you can either put in the chat or else say orally then after we do the initial set of questions. The first one then for everyone is that it's Pride Month. And so what do we have to celebrate as of the year 2021?
I mean, I think there's a lot to be proud of and to celebrate in the United States around sort of LGBT issues. I think it is definitely safer today than it was 5, 10, 15 years ago to be out not only in your personal life, but in your professional life as well. I think I'm proud of how the medical community has been moving towards understanding gender and sexuality in a more nuanced way, although there's plenty of work that still needs to be done. But everything is, at least in my mind, heading in a trajectory that is where I would want it to be seen. So that's what I'm proud of, and I'm happy to see in the year 2021. Obviously, there's still a lot of work to be done, but I mean, I would never be able to envision the career I have today working specifically with LGBTQ folks and other gender and sexual minorities. I would never be able to even envision this 10 years ago when I was in medical school. So for that alone, I feel very lucky that we are in a certain place and time where this is possible.
Thanks, Anu.
I mean, I would agree with Anu. I mean, a lot of the same sentiments. I think for me, kind of, again, going back to my son, him growing up in a world where this is more acceptable and his family isn't an other, he's in kindergarten, and at the end of the year, we asked his teachers if we could celebrate Pride with his classroom. And they were completely, on board. So, we got to read some books over Zoom. They went home with like Pride swag. And not only that, but the few days preceding that, and these are 5 and 6-year-olds, the teachers actually told them all about Pride, Harvey Milk, kind of the whole story. And so there you have these 6-year-olds kind of, with these rainbow shakers, so excited to celebrate Pride. So I think for me, and especially like all the companies now, I know a lot of it is industrial and commercialization, but it is nice that, my son can have a pair of rainbow chucks, and it's not, stigmatized as much.
And then I guess to round it off, I mean, I guess difficult thing about going last is you just end up repeating what the other said. But I mean, thinking back to Dr. Paul's timeline of where we were just 40 years ago, which was not that long ago. I mean, so much social change has happened. I mean, being gay was decriminalized. I mean, that just blows my mind that it was like actually like illegal not that long ago to be gay. But then not just that, moving forward, gay marriage. That I still remember that whole the Supreme Court fight to get there, and just how emotional that was for everyone. And a lot of my elders said I could never have imagined we would get to this point when we did. And so I think there's a lot to be thankful for. As alluded to, there's a lot of work to be done still. We can't just kind of let inertia take over. We really need to kind of harness this momentum and continue the progress that we've made thus far.
Mm-hmm. Thanks, Charles. And so the second question is then given like we still have work to do, what do you think should be the priority areas to focus on for making more progress?
Oh, go ahead, Anu.
I feel like, speaking specifically in the United States, I feel like we're living in 2 different worlds. There is spaces in the United States that are open and welcoming to sexual and gender minorities, that are open to understanding how to take care of these vulnerable populations. And then there's parts of the country that are adamantly against this. And I think a lot of the work that's left to be done is really looking into these other citizens of our country to figure out how can we support folks living there in these areas, and really trying to have a more unified approach.
No, absolutely. I mean, I think, thinking back and just, with my comments, I am very privileged, and I realize that because we live in Chicago, and I can be open and out, and we chose a city to live in based on that. And thankfully there was a job here that I could come to. But I agree with Anu. And I think the other really big thing is there's really kind of two different worlds right now. There's like the LGBT population, and then there's the transgender population. And I feel like that is the population that not on a federal level is getting kind of penalized and punished, but on a state level, there are just so many laws right now in so many different states not allowing healthcare, gender affirming hormone therapy for trans youth. Making it almost like basically the doctor, it's a crime to do it, and the doctor could go to jail. So I think there's a lot more, work and advocacy that needs to happen on that front as well.
And then, in terms of other priorities, I mean, both Sonali and Anu have touched on kind of the patient priorities. As I have mentioned many times, my interest is in educating kind of the next generation of doctors. With each class, I noticed them getting more and more comfortable with, the different terms and the different, more aware of the various healthcare disparities, but, there's still a lot of knowledge gaps and still a lot of kind of discomfort among trainees with dealing with some of these populations. And just, if anything, just to get them a little bit more comfortable using the language and the terminology, if even just to get them more comfortable, like with asking and, being more humble and just saying, I don't know, please tell me. I think that is, a continuous area for progress and to work on, just educating the next generation physicians.
Thank you, everyone. So one more question, then we'll open it up to the rest of the audience. And so my last question is, what advice do you have to allies who want to help?
I mean, I think for me, one of the biggest things, and I've seen this with, some of my colleagues, especially in terms of how to make our practice more inclusive and more welcoming, and like our work environment. And so, little things can go a long way. So adding your pronouns to Zoom identities or, your email signature, that's really big. And, having, ideally we'd want our pronouns on our badges as well, but those are little things that can be done that make, and it seems almost silly, but it's a huge step to show that one, you are an ally, and two, that you do care about these things.
I think part of also being an ally is understanding the notion of cultural humility, that, the terms we're using, how we're thinking about gender sexuality is constantly evolving, and understanding that, terminology or things you may have learned, just, 3, 5, 10 years ago can change a lot in terms of how it reflects the culture today. And being able to at least constantly ask yourself, what else can I learn? Or always being in that state of never feeling like you're an expert, because no one really is. And like Charles mentioned, always having the ability to ask when you're not sure, I think is important.
And that speaks to, you literally took away my one pearl of wisdom was, for allies, just don't be afraid to ask. We've, the LGBTQ community has been, sadly, very used to being marginalized, in a variety of arenas, including healthcare. And so, if you get something wrong, but approach it from an angle of like, oh, I'm sorry, please let me know what you would prefer, or how to address you. Don't be afraid to ask, what the patient's preferences is. It's as simple as that, and just that simple level of understanding and empathy actually goes a long way, with a lot of people, who are used to just being kind of brushed off and, not even asked, to just, something is assumed. And so, just very simple acts like that go a very long way to be an ally.
Yeah, thank you very much. So we're going to open up to everyone now. And so first, if you'd like to, please turn on your camera. It's always nice to see people's faces if you're willing to. And then you can either ask questions just live, or else you can put in the chat. Either way will be fine. So we'll just open it up.
I have a question I'd like to start with. And so first of all, thank you all so much for sharing your stories. And I think that everyone on this webinar and watching on Facebook would consider themselves an ally if they're not part of the community already. And so, along those lines, are there other resources? So there is a lot of nuance among like the terminology. And for example, I was on a Zoom meeting the other day where someone had their pronouns as she, they, and that threw me for a loop because I was used to, she, her, hers, he, him, his, and they, them, theirs. And it wasn't the appropriate time to ask. And I guess my question is are there resources where I can kind of do this research a little bit on my own without having to like burden the person in real time to ask about some of these nuances and learn a little bit more about it?
So, I mean, there certainly are. I mean, the one resource that I use a lot is Fenway Health. It's an organization out of Boston that provides care to the LGBTQI plus community, but also does a ton of education. So they have a lot of webinars and meetings. There's a lot of stuff on their website as well. I'm going to see if I can try and find the website and put it in the chat. Oh.
They direct the LGBT Health Education Center, which has a lot of really cool modules specifically for health professionals on how to navigate things like pronouns and mixed pronouns and what that means, as well as other like more concrete things of how do you implement a sexual orientation and gender identity data collection system at your healthcare system. So a lot of very awesome modules that I even find useful and that are constantly updated.
I'll kind of paste in the chat, I think a really good LGBTQ 101 article written by 3 of our colleagues here at UC, Scott Cook, Fanny Lopez, and Katie Gunter. So I'll find that link and put it in also.
That's great. Thank you so much. The internet is awash with all kinds of things. And so sometimes it's hard to know exactly where, what's the authority and where you should look. So I really appreciate that.
While people are thinking about the questions, I'll ask another question to the panel. So we hear a lot about microaggressions and to a variety of different populations. And can you tell us like what that means to you and what maybe some of the common experiences of microaggression that you've seen or experienced?
Yeah, so I mean, I can try to answer that. A microaggression is really defined as a comment or an act or action that may not have an overtly bad intention to someone, or may not be a blatant way of discriminating or enacting some sort of prejudice against someone, but oftentimes either triggers or is a touchstone for a certain reaction, particularly among vulnerable communities or oppressed folks. And so a microaggression could be someone assuming that I have a wife and asking about my wife itself. It's something that has no ill intent whatsoever, but always on the other side makes you feel like the other, or has an othering effect, which, like Sonali mentioned, all contributes to this kind of minority stress. And so it can be sometimes hard to always sort of calculate or see what the cumulative effect is, but sort of ongoing microaggressions can oftentimes get folks to be less likely to be open with you or whatnot. All the more reason to use sort of other types of language or different ways of expressing yourself that is a bit more inclusive. But I'm sure Sonali and Charles have better ways to explain it.
That's
beautiful. I mean, like, I don't have anything to add to that.
No. I mean, that's probably the most common microaggression that I get is, what does your husband do? And I've had places where it wasn't even a microaggression. It was very overt, where I, corrected the person and said wife, and then he was like, "Oh no, you mean husband, right?" So, I do think that it definitely happens for sure.
There's an interesting question in the chat about the use of the pronoun she, her, ella. That's I've only encountered that actually in Latinx communities. I think it is basic. I mean, I might be outside my realm of knowledge, but I think that is sometimes that's used in kind of like as the equivalent of like she, feminine pronouns within queer Latinx communities. If Anu and Sonali, if you're more familiar.
Yeah, so I see that they sometimes, or I would be he, him, el.
Yeah.
As a way of identifying as, it's their pronouns in Spanish essentially as well.
Question.
So I'll tee up another question to the panel that, Sonali, and this is for everyone, and you mentioned like on one of your latter slides, intersectionality and how we all have multiple identities and these multiple intersecting systems of oppression. The quotes I used had to do with like race, ethnicity, and LGBTQ identity. And there are other types of identities. And so can you tell us a little bit more about like how this plays out, that going beyond like sexual gender, minority status, how the intersectional issues are important for us to consider?
No, absolutely. And I mean, I can really, get this, kind of take my own personal experience and use it. So, I mean, I think, it's so much more. So I think, being in the LGBTQI plus and identifying within that community is already stressful for the reasons we've all kind of mentioned. And it is a marginalized community. But then for me, there was this underlying stress of, I'm South Asian. My parents are, immigrant culture, immigrated in the 1970s to the States. And there was never a question, right? It was always, you were going to marry a man. There was like no other. And so I remember, growing up being incredibly conflicted that not only could I not be I was afraid to be gay kind of in the mainstream community, but I couldn't even be gay at home. And so there was a lot of kind of internal stress and struggle that I had to deal with. And, it took a long time to get to that resiliency stage where, I've kind of made peace with who I am and how I fit in within the South Asian kind of culture. I don't know if that really answers your question though.
Yeah, thank you.
It actually brings to mind, the concept of intersectionality. Sonali touched on, the concept of minority stress and like kind of the additive, the additive stress of being in multiple disadvantaged groups, and it really compounds itself. One story, personal story, I still remember it sticks with me. And this was the 90s, so if anything, it was even a more difficult time, to be out and gay. My best friend from high school, Lily. She's a Black woman, and she tells me the story when she came out to her mother. Mom, I'm a lesbian, and her mom just kind of closed her eyes. Didn't blow up like she was afraid. Just closed her eyes, let out a big sigh, and literally said, Lily, sweetie, you're already a Black woman. Do you want to add one more hardship on top of that? And, that was like, oh my God, that's, actually, I mean, it's talk about, speaking truth. I mean, it was true. And, just, so that's the kind of, challenges that, are faced when we talk about intersectionality. Just, you're already a member of one disadvantaged group, and, now you're adding another one. So, it's a challenge. That's, I think, one of the biggest challenges to kind of address moving forward.
And I think it's important to note that intersectionality exists even within the queer community itself, meaning that racism, sexism, misogyny all also exist within the queer umbrella.
Transphobia, yeah.
Right, transphobia. So not only may you experience that among, your straight, in your straight sort of spaces, but you can also experience those same types of discrimination in your queer spaces, unfortunately. And again, so I think going back to Marshall, your question about like what, can we work on, I think is really thinking more about an intersectional way of how gender and sexual minorities are for the longest time really has been centered on, white men, gay men. And that's where a lot of the conversations have been centered and the advocacy has been centered. And I think, working towards understanding this whole other, like, millions of shades of gray in terms of experiences based on other intersectional identities is just as important. And yeah, I mean, even though Sonali and I may both be South Asian queer people, her experience as a South Asian queer woman differs very significantly from my experience as a South Asian queer cis man. So even that alone, while we may, appear similar, our experiences could still be drastically different.
Well, thank you so much, Sonali, Anu, and Charles for organizing this session and sharing your experiences. We're going to turn it over down to Aaliyah for some wrap up and I think evaluations.
Yes, although I did have one question that came to me in the chat, so I just wanted to ask it quick. It says, what do you do with family or friends who don't get it? And what are the best ways to talk to them, to talk to someone who maybe is politically or so far outside of the realm, not in a big urban center, so far outside of the realm of understanding this, like what is the best approach?
I mean, in honesty, I'm still navigating that within my own family, so I'm not sure if I'm the best person to answer that question. I mean, it's hard. I mean, right? It's, I think the last administration, I think we all found how polarizing it is, and it can be these conversations, but I don't have a good answer to that though.
I mean, sometimes it's just being present and being yourself, and as difficult as that may be, also realizing that they may never fully come around, but I think just by being present, just by being visible, that in itself is an act of courage and defiance, but also in some ways also education. And it's, we kind of need to meet you halfway,
Yeah,
that's the challenge, but at least you can start, with that.
and understanding your own limits of what you are able to tolerate, and understanding the sense of like self-preservation of if a family or a loved one or a close person is truly that toxic and not willing to, like Charles said, meet you halfway or whatnot, then understanding that it may be okay to step away if for just a bit for your own sense of well-being too.
Those are really, really great points, really tough stuff to navigate. So thank you all for getting vulnerable and sharing all of that.